This presentation will review some of the concepts that have been introduced in motor control so far and how they are or could be implemented into my current clinical practice. To begin with, we will start with what is motor control. According to Shumway, Cook, and Woolcott, they define motor control as the ability of the body to regulate or direct the mechanisms essential to movement. Movement is a critical aspect of life and essentially our essence to survive. Movement emerges from the interaction of three factors: the individual, the task, and the environment. The task and the environment create the demand for the movement, and the individual should be able to generate the movement necessary. A person's functional capacity is determined by the individual's capacity to meet the demands of the task and the environment. Within the individual, movement emerges from the interaction of multiple systems, including sensory, perceptual, cognitive, motor, or action systems. As you can see here in the chart, the I represents individual here in the center, the T represents task, and the E represents environment. With the individual, we were looking at these three concepts here. Sensation and perception are essential to the control of functional movement and provides information about where the state of the body is and features within the environment. The cognitive process broadly includes attention, planning, problem solving, motivation, and emotional aspects of motor control that underlie the establishment of intent or goals. And lastly, motor or action systems such as the neuromuscular and biomechanical systems are comprised of a high number of muscles and joints, all of which must be controlled during the execution of coordinated functional movement. The clinical implication of this would be the understanding that the body works together and not just one small section. Many clinicians, including myself at times, get focused on just alleviating the pain and restoring motion to one area that we forget about the kinetic chain. Just like in dominoes, if one domino falls, they will all be potentially affected. Shumway, Cook, and Woolcott also discuss multiple theories related to motor control. Reflex theory, which consists of a receptor, a conductor, and an effector. It is believed that complex behavior would be explained through the combined action of individual reflexes that were chained together. Hierarchical theory is characterized by a top-down structure in which higher centers are always in charge of lower centers. Motor programming theory includes problems that result from abnormalities in central pattern generators or in higher level motor programs. In patients whose higher levels of motor programming are affected, the motor program theory suggests the importance of helping patients relearn the correct rules for action. In addition, intervention should focus on retraining movements important to functional tasks, not just on re-educating specific muscles in isolation. Systems theory suggests that examination and intervention must focus not only on the impairments within individual systems contributing to motor control, but also on the effect of interacting impairments among multiple systems. Ecological theory explores ways in which our motor systems allow us to interact most effectively with the environment to perform goal-oriented behavior. Moving forward into the semester, we have focused on a few different aspects of motor control as it relates to neuroplasticity, pain and motor control, clinical movement assessment using the SFMA, core stability, and regional interdependence. To start, neuroplasticity is the ability of the neurons to modify based on the changes placed on them, according to Shumway, Cook, and Woolcott. Therefore, plasticity is not an occasional state of the nervous system. Instead, it is a normal, ongoing state of the nervous system throughout the lifespan, according to Pascal-Leon et al. In the article, Pascal-Leon discusses a subject that is given the task of 5-finger repetition, and they are asked to pay attention to the speed between individual key press and to not skip a note. What they found over a 5-day period was that the accuracy, duration, and variability between key pushes improved significantly. They also found that the cortical representation for the muscles involved increased. What this study shows us is that the repetition in motion, whether functional or not has a neuroplastic impact on the neurons. The next concept discussed was the impact of pain on motor control. The study by Hodges and Tucker discusses a new theory for motor adaptation to pain. This theory consists of 5 key elements that bring all the components discussed in this course together. The first component is pain leads to redistribution of activity within and between muscles. As you can see in the chart, a patient will report with pain and/or injury. From here, your nervous system is responding and immediately the body stiffens to splint the area and you will have an altered load distribution. This altered load distribution leads to long-term consequences due to increasing the load in new areas along with decreasing the movement and variability of the injured area, which then leads to pain or injury. As you can see, it is a never-ending circle unless you get rid of the pain. The second key to this theory is adaptation to pain changes mechanical behavior. This means that gross movement may be intact, however, quality is affected. An example of this would be the biomechanics of gait being altered after an injury. The patient is still able to ambulate, however, the way they do it is altered. Another example of this comes from the article by Kolwicki et al. As they discuss low back injuries. When compared to healthy individuals, patients with low back pain exhibit longer spinal muscle response latencies when confronted with sudden loading on the trunk. These differences may be consequences of injury sustained to the spinal neuromuscular system or may be representative of adaptive mechanism compensating for an injured or mechanical compromised spine. The third example of this comes from Kiesel et al., where they have found a decrease in the magnitude and timing of EMG activity of the lumbar multifidus during various coordination and strength exercise activities in patients with low back pain compared to healthy subjects, and a delayed activation of the deep fibers in those with a history of low back pain and remission when tested. This suggests that recruitment of lumbar multifidus is altered in patients with low back pain and with a history of low back pain, potentially reducing its effectiveness during functional tasks. The third key to this theory is adaptation to pain leads to protection from pain or injury, or threatened pain or injury. The nervous system may search for a movement pattern that is less painful when pain is present and has a wide variety of ways to protect the body involving increased, decreased, or redistributed activity. An example of this would be the inhibition of agonist muscles to reduce voluntary movement force and displacement, or increases muscle activity to splint the painful part. The fourth key is adaptation to pain involves changes at multiple levels in the motor system. Due to pain altering motor control, the assessment of painful patterns of movement may be unreliable for accurate identification of the cause of the patient's symptoms. This is where the use of a functional movement screening tool such as the SFMA will come in and be a useful resource when evaluating your patients. The downfall to the SFMA is that early on in the learning of how to utilize the tool by the clinician, the inter-rater reliability was shown to be unacceptable. It was shown to be higher in those that were more experienced in the SFMA. The final key is adaptation to pain has short-term benefits, but with potential long-term consequences. This would be best illustrated by thinking about altered gait post-surgery or injury to compensate secondary to pain in the area. However, has a negative effect on the kinetic chain, which can and or will lead to further injury. So making sure that we're getting our patients back to functional movement as quickly as possible is better in the long term for all involved. So after reviewing each of these things, the clinical implications that I take away so far from this course is that every patient is different. We know this from all the courses that we've taken up to this point, but now looking at how motor control affects it, it is very evident that we have to make sure that we are assessing our patients and evaluating what is going on with them. We need to make sure that we are treating the whole body versus one area. Even anything from as small as a little, sprain to the ankle can lead to injuries throughout the entire body if we are not treating it correctly. Therefore, this means that we need to make sure that we are evaluating functional movements versus someone just in a single plane. So making sure that we are getting a holistic look at our patient in order to be able to provide the best care possible to get them functioning at their highest capacity. Thank you for listening to the presentation. I hope that you enjoy, and I look forward to hearing back from each of you as we move forward. Have a great weekend.